pleasure to be here. It's always so great to be among you guys. I just want to say, before I get into my presentation, that 2 weeks ago today, I lost my sweet mother-in-law, Olga Smith, and then 7 hours later, I lost my mom. And so we were in a state of prolonged mourning, and I considered not coming, but then I thought, that's what you guys are all about, is moms and babies and kids. And so I just want to kind of dedicate this presentation to Rosie and Olga. Both lived long, healthy lives, 84 and 86. It was just, to lose them within 7 hours was a little bit beyond real belief. So anyway, title of my talk today is The Relative Safety of Abortion versus Childbirth, and we're going to focus on psychological morbidity and mortality. The questions that I'll address today are, what risk factors for post-abortion mental health problems are the most well-established in the world literatures? And then we'll look at what specific negative psychological outcomes have the most empirical support in the world literatures. We'll also consider how psychological effects differ with chemical versus surgical abortion. And is there evidence that childbirth is psychologically safer than abortion? So a recent literature search for articles published between 1972 and 2011 yielded over 100 studies documenting variables that increase the risk of women experiencing post-abortion mental health problems. And I should say I didn't do this lit search all by myself. I hired my son, who's a biology master's student about to finish up. He's studying schooling behavior in fish, and he has virtually no use for my research, but he really needed money right when I needed somebody to do the grunt work here, so he was a great help. My son got all these articles, and actually got about 900 for me, so based on this extensive search, we identified the risk factors that have the most empirical support, and these include being pressured or coerced by others. And that can range from very subtle pressure to overt coercion, with even in cases of abuse where a woman is told that the man will kill her if she doesn't have an abortion. So it's a wide range here when we're talking about pressure or coercion. If she's religious or views an abortion to be in conflict with her personal values, 10 studies. The pregnant woman was ambivalent about the abortion, experienced decision difficulty, or had a high degree of decisional distress, 21 studies. She was committed to the pregnancy, or she preferred to carry the child to term, 7 studies. Belief that abortion terminates the life of a human being and or the woman experienced bonding to the fetus, 6 studies. And we may wonder, how can somebody actually undergo an abortion if they experience some level of connection or bonding to the fetus? And oftentimes the way that women kind of construct it is, it's my life versus this fetus's life, so it becomes like a self-defense reaction. And the percentage that believe this is anywhere between, you would think it'd be 100%, but it's between about 25 and 50% will acknowledge that they believe they're terminating a human being. And there are a lot of studies on maternal-fetal attachment showing that, there are a couple studies in particular from Australia that showed that women fully intending to abort experienced bonding early, very early in pregnancy, and they went on to abort. But they, even with that intention, they couldn't. That it was happening in their bodies and they experienced it. She had pre-abortion mental health or psychiatric problems, 31 studies. The pregnant woman was an adolescent or young adult, 15 studies. She was in a conflicted, unsupportive relationship with the father of the child, 24 studies. The pregnant woman experienced negative relationships with others, 28 studies. Character traits suggesting emotional immaturity, instability, or difficulties coping. 42 studies document this risk factor, underscoring that profound need to really counsel women and see where they are and provide assistance. Indicators of poor quality abortion care, feeling misinformed, inadequate counseling, negative perceptions of staff, etc., 10 studies. And many of these risk factors are complexly interconnected, as exemplified in the following testimony. And this was hosted by a woman by the name of Claire. She titled it Every Day Hurts. And it's on the site of the Experience Project, which isn't associated just with pregnancy loss, or it's kind of wide open in terms of topics that are discussed, and they describe it as where people from all walks of life connect and support each other through stories. So here's Claire's story. I found out I was pregnant at 23 in February 2011. I was in a stable, happy relationship with a good job. I was so excited, I told my friends and partner, who were also thrilled. My mom found out and started talking about finances, work, etc. After my first scan, I went to surprise her with a photo. She tried to hide it and told me to put it away so no one could see. I felt like my baby was unwelcome. I realized how embarrassed she was of me, so I told myself that an abortion was the solution. On the morning of the operation at 12 weeks, the doctor gave me a scan, and unfortunately I saw the screen, which is the image now stuck in my head every day. For the past year, I've cried every day and find it difficult to look at a baby or a pregnant woman without my eyes filling up. It feels like my stomach twists and something hurts inside. As for the really crazy part, I did a pregnancy test every week after the abortion for nearly 8 months in hopes it would be positive, even though I knew it was impossible. If nothing else, I hope this makes others who have had an abortion realize that they're not on their own. And to those thinking about it, I would say that if there's any part of you that wants to keep the baby, this is not an option. So 40 years of research has shown that when specific physical, psychological, demographic, and situational factors are operative in women's lives, they are at a significantly increased risk of experiencing mental health problems following abortion. Even several abortion doctors agree on the risk factors. In 1995, Baker stated, in the cases where women do react negatively after an abortion, there appear to be predisposing factors linked to those reactions. There's enough valid research from which we can attempt to assess a client's potential for negative reactions after an abortion. Baker recommended identifying these predisposing factors prior to abortion: belief that the abortion is murder, low self-esteem, ambivalence about the decision, intense guilt and shame about the abortion, perceived coercion to have an abortion, and commitment to the pregnancy. Even the APA, and when I wrote to see APA, I want to talk for an hour about their report, but I'm going to resist right now and just mention that in their report that generally was very biased and not reliable in terms of the evidence that was assembled, they had to acknowledge risk factors because they are so prevalent in the literature. So even the APA report acknowledged if a pregnancy is wanted or meaningful, women are more likely to have problems afterwards. If there's pressure, opposition to the abortion from partners, family, or friends, if there's a lack of social support, commitment to the pregnancy, ambivalence, low perceived ability to cope, the same themes are being echoed everywhere. And so despite the availability of strong research documenting risk factors and professional awareness, abortion providers rarely, if ever, routinely screen for risk factors and counsel women at risk. And before I switch to the psychological consequences, I just want to explain a little bit about a case in South Dakota which shows some hope that women will be counseled on risk factors, thanks largely to Harold Cassidy and his work on behalf of the interveners. And it was 1217 is the case, but we were successful in putting together this information on risk factors, and Planned Parenthood eliminated the claim, and so they backed down. We don't have to fight for the risk factor clause, or whatever the appropriate term is. We now don't have to do any more in terms of documenting this evidence. We presented it, and it was so strong in the professional literatures that they realized they didn't have a chance trying to fight that. And so women in South Dakota will be warned of about 10 different risk factors, and they'll be counseled. And if they happen to fall in a high-risk group, then they maybe will think twice about the abortion. So this research is slowly having an impact in the U.S. and elsewhere. So now we'll look at the psychological psychological consequences, and there's an abundant literature comprised of methodologically sophisticated studies from around the world that now indicates abortion significantly increases risk for several mental health problems, including depression, substance abuse, and that is both legal prescription drugs and illicit drugs, alcohol, anxiety, suicidal thoughts, and behavior. A minimum of 20% of women who abort suffer serious, prolonged, negative psychological consequences. Abortion is further associated with a higher risk for negative psychological outcomes when compared with unintended pregnancy carried to term. And the data indicate that risk for long-term psychological injury is considerably higher with abortion than with other forms of perinatal loss. Abortion-related psychological problems may also increase a person's chance of engaging in self-harm, even if not motivated by suicidal thoughts directly, and becoming a victim of an accident or violence. So we actually have some data that we're currently collecting, and it's a national study, and we've had the assistance of CareNet in terms of alerting people who may be coming back to a center for post-abortion care and so forth. And so we really have a great deal of help from CareNet in terms of announcing this study. And the Alliance Defense Fund was kind and generous in supporting this effort. And so we now have almost 1,000 completed surveys, and some of the items relate to this topic, so I did some preliminary analyses. In response to the items, she looks pretty bad. That's how I feel. I've been feeling the last couple weeks. But in response to the item, because of the abortion, I stopped taking good care of myself, 14% strongly agreed, 28% agreed. And then alarmingly, among these women who have actually agreed, 73% said it lasted for 3 years or more. In response to the item, I tended to take greater risks after the abortion because my personal safety was less important to me. 32% strongly agreed, 16% agreed, and among these women who agreed, for 72%, this lasted 3 years or more. With regard to the item, I engaged in more casual sexual activity after my abortion, 40% strongly agreed, 18% agreed, and among these women who agreed, for 64%, this lasted 3 years or more. In response to the item, I drank alcohol excessively as a result of my abortion, 18% strongly agreed, 21% agreed. And among these women who agreed, for 57%, it lasted 3 years or more. With regard to the item, I used illegal drugs following the abortion because of the distress that it caused me, 8% strongly agreed, 11% agreed. So among these women who agreed, for 71%, this lasted 3 years or more. In response to the item, I relied on alcohol and/or drugs to escape troubling post-abortion emotions. 24% strongly agreed, 24% agreed. And among these women who agreed, for 56%, this lasted 3 years or more. In response to the item, life felt like it wasn't worth living because of the abortion. 30% strongly agreed, 14% agreed. And among these women who agreed, for 63%, it lasted 3 years or more. And then with regard to the item, I thought about taking my life because I had the abortion. 14% strongly agreed, 19% agreed. And among these women who agreed, for 32%, it lasted 3 years or more. In response to the item, I made realistic attempts to take my life because of the abortion. 3% strongly agreed, and 8% agreed. And among these women who agreed, for 25%, this lasted or occurred 3 years or more post-abortion. So now I'd like to kind of switch gears here and talk about some of the strengths of the studies that have been published in the last decade. We have much larger samples. Many are nationally representative. The study that I just went over was more of a clinical sample because women who are willing to take an hour out of their day to complete an extensive survey may have worked through that abortion more, maybe at a different place. Psychologically, it's not a normative sample, but what we're hoping to get at is and this wasn't mentioned in the slides, but we're really trying to understand the decision process in a more substantive way. So there's a lot of open-ended items where women can really share their stories, and so it will be a mixed method approach. We'll be looking at analyzing the data both qualitatively and quantitatively, but sort of opening it up now to the larger literature, we do have much larger samples, and we have controls for prior psychological history. We have controls for personal and situational variables associated with the choice to abort. So our efforts to tease out that independent effect of abortion are much more valid. We have more long-term data collection with low dropout rates. We have use of appropriate comparison groups. In the study that I just talked about briefly, the comparison group, and we only have 80 women who fall in this category, but the comparison group is women who actually went to an abortion provider and changed their minds. And so then we're effectively equating them fairly well in terms of socio-demographic factors, relationship factors, and so forth. And then there are much more comprehensive measures of mental health, often with actual diagnostic codes assigned by professionals. In the past, a lot of the studies published like in the 80s, early 90s, might have contained like one item, or a couple items where women were asked, have you been more depressed since the abortion, have you been more anxious, but they're not psychometrically sound instruments for measuring the variables, or they're not diagnoses that have been assigned by trained professionals. So the studies out there today have much better outcome measures. And I could cover a lot of studies that have come out in the last few years, but I decided to focus on the most recent ones because I did speak here last year, and I was trying to make this presentation as different as possible from last year. But these are a couple of new studies. In France, Rousset and colleagues, 2011, it was published, conducted a study of 86 women who had a surgical abortion, that was 63%, or a chemical abortion. And they were recruited from family planning centers and 2 general hospitals in southern France. The reason I chose this one was to kind of highlight some of the differences to women psychologically between experiencing a surgical abortion and experiencing a chemical abortion. So at 6 weeks post-abortion, when assessed with a post-traumatic stress disorder measure, 20% had scores indicating acute stress and 38% had scores indicating actual PTSD. Bereavement, grief, and PTSD scores were significantly higher among women who had a chemical abortion compared to surgical abortion. And the researchers concluded, quote, these results evidence the complexity of coping with abortion and emphasize the need to develop specific support as well as preventive strategies. Their work was consistent with earlier studies comparing chemical and surgical. Slade and colleagues back in 1998 found that compared to those who had a surgical abortion, those with chemical abortions rated it as more stressful and experienced more disruption in their lives. Ashtok and colleagues in 2005 reported 46.8% of women undergoing a chemical abortion experienced a significant decline in self-esteem 2 weeks following abortion. This was a higher percentage than among those who had a surgical abortion, 39.5%. Kelly and colleagues, 2010, reported women who underwent chemical abortion had higher PTSD intrusion scores, nightmares, unwanted thoughts and images than women who had surgical abortions. They also reported 47% of women who underwent chemical abortions indicated they would not choose the method again, and 53% felt that the procedure was worse than expected. So why would we expect psychological trauma to be more significant with a chemical abortion versus surgical? There haven't actually been studies that looked at the mechanisms here or explanatory for the explanations, but some of the hypothesized reasons include the participatory role of the woman. The woman is directly responsible for the abortion, and this may exacerbate guilt and other negative self-directed thoughts and feelings. Also, it requires the woman to be more alert and involved during the process, making it impossible for her to distance psychologically from what's happening. The woman may see the expelled fetus. The woman's more likely alone and without emotional support at the time of the abortion. As researchers Slade and colleagues stated in 1998, one of the main differences between these two methods of termination is the consciousness of the patient in the medical procedure in a process that involves blood, pain, and death. Another study from China, data were derived from the anti-birth defects in child development cohort study analyzed by Huang and colleagues in 2012. It was published. Large sample consisted of nearly 7,000 women, 47.6% of whom had experienced at least one abortion. Women with a history of induced abortion a year or more prior were 49% more likely to experience depression and 114% more likely to experience anxiety in the first trimester of a later pregnancy compared to women who had not experienced an abortion after controls for maternal education, income, place of residence, and BMI were applied. There were no differences between women with and without a history of spontaneous abortion. And so I'm going to talk a little bit about the meta-analysis. The strongest studies published between 1995 and 2009 are synthesized in my recent meta-analysis published in the British Journal of Psychiatry. I'm going to talk a lot about it. I think I talked about it the last 2 years, but just in case you missed it or want a little summary here. And most of you, I'm sure, know what a quantitative review is, but by systematically combining the numerical results from many high-quality studies addressing the same basic question. In our case, the question is there an association between abortion and mental health? Very reliable results are produced. Studies are weighted statistically, and meta-analysis offers a logical, more objective alternative to traditional reviews. And interestingly, this is the only existing meta-analysis on mental health effects. The other side is systematically avoiding doing a quantitative synthesis because the numbers will not be in their favor. And so, this was very greatly needed in some of the cases that I've been involved in, state and civil cases involving abortion, because one of the first things they do is they put the APA report in front of me, or now the Royal College report, and they'll say you're just one little researcher from Ohio versus the American Psychological Association, expert panel, and this kind of trumps that because it is a quantitative review involving almost 1 million women, and so that was the idea, that we needed to counter these very biased narrative reports that are out there. And the Royal College one was even worse than the APA. And initially, some of my colleagues, friends, thought it wasn't too bad. And I went over the problems with the Royal College report. It was a 250-page document. And last year, I went over some of the issues. But just very briefly, they eliminated all studies. They were looking at the long-term consequences. So they eliminated all studies that were within 3-month window of the abortion. Well, excuse me, but people who are most adversely affected, it's going to happen right away. So it was just ridiculous. And so those narrative reviews are influencing policy, they're influencing the training of professionals, and we really need to have good objective evidence. And so that was my goal here. And the inclusion criteria that I used were a sample size of at least 100, use of a comparison group, either no abortion, pregnancy delivered, or unintended pregnancy delivered, one or more mental health outcome variables, depression, anxiety, alcohol use, marijuana use, or suicidal behaviors. There were other outcomes in the literature, but there weren't a sufficient number of studies in other categories to include. Also, the studies had to have controls for variables associated with the choice to abort. So the first meta-analysis, which included 36 adjusted odds ratios from the 22 studies identified, resulted in a pooled odds ratio of 1.81. And this means women who have had an abortion experience an 81% higher risk for mental health problems of various forms compared to women who have not had an abortion. And then this graphic shows the pattern of results. So even though you can't see the details from where you're sitting, you can see the pattern. And the fact that all of those horizontal lines are shifted to the first quadrant to the right of the center line shows a systematic pattern there that is happening in the literature. A second meta-analysis was conducted with separate effects based on the type of outcome measure. So I looked at studies that incorporated marijuana use, suicidal behaviors, alcohol use or abuse, depression, and anxiety. And the level of increased risk associated with abortion varied from 34% to a high of 230%, depending on the nature of the outcome. The highest one was marijuana. And really, if you look at all of the literature on psychological trauma or adverse mental health outcomes associated with abortion, the substance abuse literature is probably the strongest. And we see the greatest effects there. And it's likely because many women don't share this experience of abortion with anyone else. And that's an easy fix in our society. You get a prescription from your local doctor for an anti-anxiety, antidepressant drug. You don't have to tell why you're anxious necessarily, or grab something to drink. It's just such an easy, fast fix for women who would rather not deal with it or share it with someone else. So, very sad that when we see the prevalence of substance abuse disorders in our society. In a third meta-analysis, separate pooled odds ratios were produced based on the type of comparison group. So here I divided up the effects based on no abortion, carried to term, or unintended pregnancy carried to term. And I think there were 8 studies that actually had the unintended pregnancy. And then depending on the type of comparison group, abortion was associated with between a 55% and 138% elevated risk of mental health problems. Then looking at the population attributable risk, or PAR, percentages from the pooled odds ratios, we were able to definitively say that nearly 10% of the incidence of mental health problems was directly attributable to abortion. And I don't know how many of you read the recent review that Dr. Thorp published. I don't think he's here. I haven't run into him. Is John Thorp around? Not here this time. Anyway, just a couple of his conclusions related to the mental health area. He said that the findings are mixed and subject to methodological shortcomings, that numerous studies from the vast literature indicate harm associated with abortion, and he references over 100 studies in his review. And then the 10% PAR, he said, from the Coleman meta-analysis underscores the need for continued research, attention, as women who abort experience, quote, a disproportionate share of mental health problems. So now I'd like to shift it again and talk about some of the psychological benefits of motherhood. A number of studies have shown positive psychological characteristics, including an increased sense of control, feelings of serenity, self-esteem, empathy, ego resiliency, which is the capacity for flexibility and resourcefulness in coping with stressors, and assertiveness associated with motherhood. According to Ellis in 2005, frequent close contact inherent in daily care of a young child results in expanded maternal brain activity and neural growth. And as mothers monitor and attend to children's needs, brain circuits related to empathy are expanded. According to Fleming, a researcher at the University of Toronto, elevated cortisol levels in new mothers may boost attention, vigilance, and sensitivity. And this study was particularly well done based on the comparison group when comparing 248 British women experiencing a planned pregnancy to 182 women experiencing an unplanned pregnancy. DEEV in 2005 found that 87% of women who planned their pregnancies and a not far off figure of 79% of women who did not reported feeling pleased or overjoyed just prior to delivery. They were all first-time mothers residing in lower socioeconomic areas. In a study that had nearly 400 participants, Rokash, 2004, reported mothers in their first year of parenting scored significantly lower on a loneliness questionnaire than a subsample of women from the general population. The subscales included emotional distress, social inadequacy and alienation, interpersonal isolation, and self-alienation, which involved detachment from oneself or feelings of numbness. This is my favorite slide. Those are booby cookies, if you want to copy that. If women breastfeed, there are additional benefits as lactation produces the antidepressant chemical oxytocin. Studies suggest lactating mothers are less tense and become bored less easily than their non-lactating peers. The hormonal activity and neural circuitry associated with childbirth and lactation reduces depression and anxiety. Carter and Jan Voss Marburg, not very great with the pronunciation, leading authorities on oxytocin have provided scientific evidence suggesting that the brain becomes more receptive to the impact of oxytocin after the first heavy dose during labor and breastfeeding. Hormones of pregnancy and early motherhood apparently facilitate formation of subsequent strong personal relationship bonds. But what about postpartum depression? The incidence rate for postpartum depression is between 3.4% and 11%. However, this form of depression tends to be less serious than major depression, which has been shown to afflict as high as 20% of women after abortion. Moreover, postpartum depression is very rarely found to precipitate suicide. And childbirth is protective against death due to suicide. Several studies document this. Gisler and colleagues, 2005, reported the annual suicide rate for women of reproductive age to be 11.3 per 100,000, whereas the rate was only 5.9 per 100,000 in association with birth, and was a startling 34.7 per 100,000 following abortion. Several other studies have revealed even lower rates of suicide in the year following birth when compared to non-postpartum samples. In the U.S., the postpartum suicide rate was found to be only 1.4 per 100,000 by Schiff and Grossman in 2006. In the United Kingdom, Kleiner and Justin in 1984 reported a very low rate of postpartum suicide of 0.5 per 100,000 live births. England and Wales, a population-based study by Appleby, 1991, reported in the British Medical Journal that pregnant women are 1/20th as likely to commit suicide when compared to non-pregnant women of childbearing age. Appleby concluded motherhood seems to protect against suicide. Then I'd like to share the story of Stacey Zally, who lived a very short life. At age 20, as a result of pressure from her boyfriend, Stacey underwent an abortion. Shortly afterwards, she asked for psychiatric help, but she ended therapy after only 3 months. Sadly, after several suicide attempts, she hung herself in her room. Her parents didn't know about the abortion until after her death. In the suicide note, she expressed desire to be reunited with her unborn baby, whom she named Brittany Lee. And I served as an expert on that case. George Zally, Stacey's father, sued Stephen Brigham, which is a name that he's probably familiar with. It was a long, drawn-out, difficult lawsuit. Byron Calhoun also was involved in the Stacey Zally case, but it was very, very sad. The psychiatrist never even identified the abortion as a stressor in her life. She was never treated for the depression with medication. She was never hospitalized. And this is 3 attempts before she hung herself in her room. Very sad. The personal impact of abortion is often profound human suffering, with the most serious cases like that of Stacey Zally entailing lives full of potential, needlessly ending long before they should. Continued denial and distortion of the literature by abortion clinic personnel, the media, and professional organizations leaves hundreds of thousands of women untreated like Stacey. Each day, a significant number similarly find the shame, loss, and depression of abortion simply incompatible with life. So let's take a look. This is our grandson, David, on a happier note, trying to get up the tree. So we'll take a look at some of the current challenges and future research direction. The lack of empirically validated treatments has left many women without much hope for relief if they experience post-abortion psychological problems. So an essential for a future goal is to develop treatment protocols, test them, and publish the results. Also, data collection from significant individuals in women's lives and/or behavioral assessments will enhance our efforts to assess the complexity of women's experiences. Most of what we have now is just self-report. Also, researchers need to conduct more substantive interviews with geographically diverse samples in order to more fully understand the depth and breadth of experiences. Short-term studies are potentially misleading because women may suppress their emotions until other life events, such as a birth, trigger a delayed reaction. There's a need for studies following women over many years to more fully understand how abortion experiences intersect with other life events to impact women's quality of life. In a small qualitative study by Slade and Haywood, just published in 2010, it was titled Long-Term Follow-Up of Emotional Experiences After Termination of Pregnancy, Women's Views at Menopause. The authors reported that many women were still affected by an abortion that had occurred decades earlier. Women discussed menopause as a vulnerable time that had made it increasingly difficult to manage their feelings about their past abortions. As one participant noted, quote, "It's only since the menopause has come on that I actually feel really guilty again. I mean, I sometimes sit on my own and I've cried because I feel guilty, but I've noticed that has happened more obviously since I've gone into the menopause." For some women, menopause was associated with the loss of fertility and future opportunities for more children. The authors noted, quote, "There's a sense of not being entitled to express sadness at having no further children. Rather, there's a feeling that this right was lost when they had an abortion, and these women should accept and bear their current state without emotion. They somehow deserve this punishment." The authors concluded the work provides insight into the very long-term consequences of this procedure. Participants stressed the value of being able to discuss the abortion with a neutral third party, to be able to voice some of the thoughts, confusion, and sadness some had carried alone for so long for fear of repercussion or judgment. It's likely that women may benefit from the availability of post-abortion counseling services, not necessarily just in the immediate aftermath, but at different points after the procedure. The risks of post-abortion mental health problems are generally well established in the professional literature. The biggest challenge before us is to convince the mainstream, healthcare professional organizations, and lawmakers to approach the scientifically derived information objectively to develop evidence-based laws and service protocols. Then with the scientifically derived information, commitment, and compassion, we can assist individual practitioners as they endeavor to provide the highest quality of health care to women. And we can trust that more women will make healthy decisions in the future. There's Aiden again, our grandson. Thank you very much. I guess we have time for 2 questions, Mary said. So, anybody has any questions? Yes, Lottie?
Thank you for your very nice presentation and all the work you do, Dr. Coleman. Is there any evidence that women who have had an abortion and then have a wanted or a full-term pregnancy, that their mental health is any different? I mean, is there a group that's been studied like that?
Well, we actually published a study in 2002, and it was in the American Journal of Obstetrics and Gynecology, looking at women in a later pregnancy, women, and the histories included women who had an abortion and women who had not. And we saw much higher rates of substance abuse, especially marijuana was 10 times higher in those women, in a later pregnancy, whether it was wanted or not. We didn't have that data, but in that subsequent pregnancy, there was more substance abuse when there was an abortion history. And I think there's clinical data, there's anecdotal data suggesting that women who have wanted pregnancies later often have trouble bonding. They either will be over-connected to enmeshed with the kids and not allow the appropriate autonomy that they need developmentally, or they are too kind of neglectful, afraid they'll somehow lose that later child, and so they hang back too much and they don't connect. So I think the potential to disturb later parenting is great, and there have been a few studies. I actually wrote a review sort of looking at perinatal loss and later parenting. I'd be happy to send that to you. Yes?
You have mentioned enough times the difference between women who deliver to term versus those who choose to abort following an unexpected pregnancy. What if that unexpected pregnancy is a result of rape or incest? What is whether the woman decides to deliver to term and adopt versus deliver to term and keep the child? What has studies showed there?
Well, there hasn't been enough systematic examination of rape, cases of rape, and rape is pretty rare, as we all know, with pregnancy is pretty rare with rape, but like I was just looking at Spanish data. I have all data on all women in Spain who opted for an abortion in 2008, and the reason given was only 27 cases out of like over 100,000 were due to rape. But I think the data that's out there suggests that women who proceed to terminate after a rape feel doubly victimized, that it doesn't solve the problem, it makes things worse. And so, that's it. Thank you.